So this is the here is the title of the lecture, Topography of the Pelvis Review. No, we can divide it into some parts. First of all, I would like to start with one diagram showing the topics and explaining the situation in the pelvis. This is just a diagram showing the sagittal section of the female pelvis for orientation, starting with the pubic symphysis. Here you see the urinary bladder, vesica urinaria. Then follows the uterus with the fundus corpus, cervix, then the vagina with the posterior fornix, then follows the rectum with the typical curvature, following the position of the sacrum, dorsally posteriorly. This diagram, in fact, shows two spaces. One is because we follow also the covering of the organs, peritoneal covering, while we see the parietal peritoneum descending and covering the organs as the visceral, then passing around the uterus and also forming here the deepest depression, which is called excavatio recto-uterina, recto-uterine pouch, which is the deepest part of the peritoneum, and also covering anterior surface of the rectum. So we see the organs which are situated under the peritoneum. We call them subperitoneal organs. Also the space is subperitoneal, and the organs which are situated in the peritoneal cavity. So the organs belong to the peritoneal cavity, including the organs which are situated close to the posterior wall. That means the great vessels, the kidneys, ureters descending here. So these organs are retroperitoneal. So you see the continuity of the retroperitoneal organs with the space called infraperitoneum or infraperitoneal organs. So this is just for introduction, and we would start with a short review of the organs or structures found in the pelvis. So I mean that we can divide our topics, because this is a rich program for today, into the walls. We could say walls of the pelvis, because we are speaking about the lesser pelvis, definitely. And number two will be very short review, a review of the, or better, we could say, very simple, because we will speak about the genital organs. We have to know also the origin. So we could say development, very short review, development of urogenital, maybe it's the best one, urogenital genital organs, and we could say short review, because this is just short review. We know that the embryology will be explained by embryologists, but we don't have time. We cannot wait for them. We are faster than they are. We have started with the explanation of the development. We already started, so that means we have to go. And then follows number three, which will be the perineal region, or perineum, maybe perineum, because this is the floor of the pelvic cavity, plus urogenital, everything together, urogenital diaphragm, because perineum is divided into the anal triangle and the urogenital triangle. So this will be explained together, the urogenital diaphragm. So there are three steps which should be completed today. Very quickly, well, we have seen diagram. I would start again with one more. This is, we will not draw everything, because you can find it in atlases, but one diagram must be explained. It doesn't matter if it is a male or female. So this is a good example of one sagittal section or paramedial section of the male pelvis, where we see the peritoneal covering. This is what we said, the depression here, which is the in female, we call it Douglas's pouch, but we can call it heel also. But this is the rectovesical pouch, deepest pouch in the peritoneal male cavity. And then you see the attachment of the apex of the urinary bladder to the umbilicus in the anterior wall. Then the space which lies behind the pubic symphysis. This is retropubic or pre-vesical space. Then we see the space behind the bladder. This is the retrovesical, and where we see also some ligamentous systems and also the connective tissue, then seminal vesicles. Then a very important lamina, which descends from that depression in the pouch of Douglas and is connected with the central tendon we call the retrovesical septum. The septa help in stability of the organs, and the grayish color shows the spaces which contains the soft connective tissue, vessels, lymphatics, etc. And then dorsally posterior is the rectum which copies the shape of the sacrum and coccyx, and caudally there is the external sphincter. So we see the spaces. The organs situated below are the infraperitoneal, the other ones situated above are peritoneal. I will speak briefly also about the external genital organs, but not explaining details, but just to mention their position and also topographical relations. So back to our topics. We start with number one at number one. Yes, we could start with number one, and we could say some words to the topography of the pelvis. No, it's not complicated. When we try, because this is again the illustrated anatomy, just sketching this will be coronal section. Always we have to mention the orientation of the sections, and it must be uniform forever, because if we will not organize the things in anatomy, it's not possible to do just the notes without any explanation. Okay, so here just sketching. Here is the greater trochanter and the femur sufficient. Then we see the pelvic bone, and then here's the lower end, and then approximately this will be correct situation. So our color here is the lamina, is green. This is the obturator membrane that just very quickly drawing the outlines of the pelvis and the lower part. This will be yellowish. And then we see that we can divide, because using also the blue color to show the covering by peritoneum. So bluish is the peritoneum. So we said that peritoneum, that one is the greater pelvis, definitely. So bounded by the wings of the greater pelvis. That means we could say greater pelvis, correct. And here is the lesser pelvis, definitely. So we will speak from now about the pelvis. From now onwards, about the lesser pelvis, the cavity, because the organs are infraperitoneal, because the peritoneum here clearly explains the whole situation. So we try to color the cavity, which lies at the center of our interest now, lesser pelvis, and then using light green, for instance, there is also one space, a relatively narrow space, which is called the perineum, or also perineal region, perineum, or perineal region. Both terms can be used. So we are in the inferior part, which is in fact the floor of the pelvic cavity, and also contains the urogenital diaphragm. Now, concerning the adductus, entrance is called simply, because we already defined it when we studied the bones of the pelvis. So we call it superior pelvic aperture. We remember at that time when we defined the diameters, transverse diameter, oblique diameter, straight diameter, etc. And then here is the inferior. Again, the same would be inferior pelvic aperture. But pelvic aperture, good, called also adductus pelvis, Latin, pelvis And here is the exitus pelvis, right? Exitus pelvis, bounded also, as you know, by the inferior part of the pubic symphysis. Then ischial tuberosity, sacrum, and coccyx dorsally posterior. That's it. So don't forget that here would be also the urogenital diaphragm. This is what we said at the beginning. Urogenital diaphragm should be also studied. Diaphragm. Okay. So this is just the diaphragm. Orogenitale will be reddish because this is muscular flora. Okay, so this is what we mentioned. Just the, the situation, and then we will speak about walls of the pelvis. But first of all, we have to say some words to the development of the maybe that we could do first of all, really, we can say some words to the walls of the pelvis, and then we will return to development. This will be even better. So concerning the walls of the pelvis, we remember that the wall or the walls are divided into the anterior, lateral, and posterior. So concerning the walls, we start with the, I would say, walls, and then some words to each, because there are some specific things which should be mentioned. Concerning the walls, yeah, vertical. Okay, starting with anterior, we start with the anterior wall. Fine, anterior. So what we see anteriorly? What we see anteriorly? We remember that, look again at the diagram. Anterior is the pubic symphysis, some vessels. The vessels should be discussed, and also the soft tissue and spaces. So concerning anterior relations, because we speak now about the relations, definitely. So must be pubic, starting with the pubic symphysis. Number one, symphysis, pubic symphysis. The points, just the points, pubic symphysis. It must be P, correct and good, P, pubic symphysis, fine. Pubic symphysis, and behind that lies also the branch, ramus pubicus, pubic, which is a variety but important for clinical medicine of ramus pubicus of the inferior epigastric artery. We remember that inferior epigastric artery is the artery which lies on the posterior surface of the anterior wall and lies between the the openings of the inguinal canal. That means the superficial and deep inguinal ring. So this is the ramus. This is the inferior epigastric artery. Then follows what? Then we have what else? We will speak about the ramus pubicus together with some varieties on the lateral wall. So stop with that. And then we could say laterally, the lateral wall, laterally. And laterally, what we see? No, of course, definitely the bones of pelvis, bones of lesser pelvis, logically. So then the obturator membrane, here we have that obturator membrane, obturator membrane. We know that obturator membrane plus muscles, definitely, but obturator membrane contains also the obturator foramen and canal. We call it obturator canal, obturator foramen and canal. And we remember that through this obturator canal and foramen pass the nervus obturatorius, plus artery plus vein, obturator, again, this is the same name, obturator, artery, vein, and nerve. And then there is the place to encircle the ramus pubicus, pubic branch, and this artery, the obturator artery, and we see the variant of this artery, of these arteries. Look here, I'm joining them because there is the connection. We call it anastomosis of this variant, of these two. And this is well known in the terminology of surgeons under the name corona mortis. Corona mortis. If you can look in some books, atlases, you could see that corona mortis means what? No, this is the situation in the history. This is not now, definitely not. In history surgery, during operation of the hernia, for instance, they cut that variant. I don't remember at the moment if this is around 8, 10, maybe percent, or even around that, or even less than that. But in that situation, they cut it, and patients died because of bleeding into the abdominal cavity. That's why they call it corona crown mortis. This is that head or crown of head. So because this is fatal situation, if they cut it, this anastomosis between two vessels, then it's very risky situation. Good. So we put again the points: bones, obturator, then the obturator artery. What else? No. Then there is the obturator muscle, internal obturator muscle, internal obturator muscle, plus its fascia obturatoria. Don't forget that the fascia is important because the fascia forms the duplicature very quickly, important for the ischiorectal fossa. So I'm using this opportunity to draw immediately the coronal section, because we will save coronal section. Green, yes. We see the wall of the rectum, canal, anal canal, floor. Then the wall of the rectum, fine. Attachment of the levator ani, then the internal obturator, and then the bone. And here is the duplicate. Look, so if we are coloring the bone, just this is the coronal section. Then looking at the muscles, good. This is the levator ani with the puborectalis. And then using red for the internal obturator, and this is the wall of the rectum. This is quite logical. Fine. So we see the rectum. So rectum, yes, rectum. Then bone not necessary. This is the internal obturator muscle, internal obturator. It's fascia, using green, covering the muscle, covering also levator ani on both sides. And here's the duplicature. I'm drawing much bigger than it is. It's just a small duplication, but important for us to know that there is the pudendal nerve, pudendal artery and vein. That's it. So without any details, because we will speak about that also at the end of the topic, we see this fascia. So look, this is that fascia. And here the canal here is called pudendal canal. Pudendal canal. So simply pudendal canal, Alcock's canal in surgical terminology, pudendal canal. As we said, the fascia forms the duplicature, which contains the pudendal nerve and vessels. So it contains the pudendal nerve plus internal pudendal vessels, artery plus vein. That's it. So now we know that it lies also on the lateral wall. No, and that space here is not bad to remember that fossa, which contains soft connective tissue, using just very light green. This space is called ischioanal or ischiorectal, or ischio. In some books, ischioanal, because it's close to anus, bounded by the wall of the rectum, then internal obturator fascia, and also levator ani. Is called ischiorectal fossa. This will be topic also, which should be explained together with the perineum. Fine. So we see the space. Don't forget that one is the levator ani. Maybe that is not bad to add levator ani. LAM, levator ani, levator levator ani muscle. Fine. So we are now sure about the position of the structures, but this is not all, because we have to say also some words to the posterior. We see the walls anteriorly, laterally, and then must be also the posterior wall. Okay, starting with the posterior. What do we see posteriorly on the wall? Posteriorly, right? Posteriorly, no. Dorsally posteriorly, what we see, this is a continuation with the retroperitoneal space. Just quickly, we know that this is the continuation. It's continuous with the retroperitoneal space. Finished. And what we see dorsally posterior, this is not complicated. First of all, must be sacrum plus os coccygeus or coccyx plus the ligament. We will speak about the ligament later. This is called anococcygeal ligament. We will see it in one of the diagrams. This anococcygeal ligament is important as a stability of the anus related to the dorsal wall. Number one. Number two, there is the sacroiliac joint plus its ligaments of the joint. Also clear, already done. It's typically amphiarthrosis. The next one are the great ligaments. I would say ligaments, abbreviation colon, and we know this is sacrotuberose, and sacrospinous. These two ligaments, as you remember from the description of the walls of the pelvis, the bone in pelvis at the beginning, that means in October in practical sessions, these ligaments form the foramina. We remember that are very important foramina. We know this is the minor sciatic foramina. I will call it sciatic. They form the sciatic foramina. And without any foramina, without any details, just for revision, very, very brief revision. This is major, as you know, major foramen, and minor. Major is much bigger, and as you know, it contains the piriform muscle, musculus piriformis, piriform muscle, dividing the major foramen into two smaller sections, parts, and we call it supra and infra piriform foramina, and then suprapiriform contains nervus, artery plus vein. No, which ones? Superior gluteal. Of course, the official name would be nervus gluteus superior, arteria vena glutea superiora. Finished. This is quite logical. But infrapiriform foramen is more complicated because it contains more structures, much more, starting with the same. This is like the nervus, then artery plus vein. This is the inferior gluteal vessels. Then follows the sciatic nerve, nervus ischiadicus, very important, large, big one, the biggest nerve in our body. And then pudendus, pudendal nerve. Then pudendal vessels, internal pudendal vessels, artery plus vein, and also sensory thin nervus cutaneous, nervus cutaneous femoris, posterior cutaneous nerve, sensory sufficient. Done. These structures are quite clear, but the only pudendal nerve, internal pudendal artery run very specifically. They run around the spina ischiadica, ischial spine, doesn't matter. We can use also the Latin word spina ischiadica, ischial spine, runs around, passing into the minor foramen, and then returning to the pelvis. So the only nerve, pudendal nerve and internal pudendal vessels, they originate from the Alcock's canal, as we said, passing through the infrapyriform foramen, as we said, foramen, and passing around, turning around the spina ischiadica into the minor, and then leaving the minor foramen into the pelvis. So this is the explanation. Well, topography is done. No, and then there is a right time to say some words to the or mention something about the development of the internal of the organs, definitely of the urogenital system. So this would be number, as we said, number 2. The system, the organs. Just we said very short review. I would say just development, just notes, development, and just notes, short review and notes. No, when we look at the development of the organs of the urinary system, or urinary organs, and the organs belonging to the genital system, we could divide it simply into the urinary. So first of all, urinary, we have to know some words only. Urinary system, urinary organs, you can say. Concerning the urinary system, we know that we start from the aorta, and also the vessels that, I mean, we are speaking about the filtration of the blood. So the system consists of the vas afferens, transmitting, bringing the blood to the glomerulus. This is the capillary glomerulus, and then this runs not returning, runs in the other way, and then it's the filtrating system, starting with the first stage, which is called pronephros, Greek words. Then will follow another one, starting with the Bowman's capsule, and then finally the last one, which is much longer, forming also the fully developed Bowman's capsule. So we call it, this one is called glomerulus, capillary network. Then that vessel is called vas afferens, bringing afferens, and that one is vas efferens. Vas efferens. Vas efferens, transporting the blood, and then here is the urine. I mean that we can color the canal that interconnects all these systems, developing systems, and we call them, first of all, number 1 is called pronephros, the first stage, because there are stages. Pronephros, primitive stage, appearing in the fourth week, week 4. Then follows the mesonephros, because here is the vas afferens and deeper glomerulus. And finally, the last one, which is even deeper, and it belongs to the kidney. So the second one is mesonephros, 8th week, so replacing the pronephros. And finally, the last one is the metanephros. And no, metanephros, in fact, is the ren, is the kidney, ren or kidney. The ren will appear, as you could see. This will be like that. We are just looking. This is that one. Moment. It must be. Very important name is the Wolffian duct. Wolffian duct. This is ductus mesonephroticus. I will use also Latin word ductus mesonephroticus, fine. Wolffian duct. When we look at the final stage, the REN, the kidney. So again, we could just complete it looking at the kidney. At the kidney, there is the ureter, and here is the kidney, right? So we see the pelvis and the kidney. So just to know that metanephros is the final stage called kidney. Of course, repeating again, here is the ureter, and then repeating the same color is the Wolffian duct, right? It's the same Wolffian duct, and then the kidney. So this is the REN or the kidney. Fine. So these names are important, especially the Wolffian duct is important to know. This is one thing. No, and then on the next page, we would start with the second part. This means the genital system. So we started with the urinary system, and the second one will be the genital. So they are very quickly genital organs. No, as we said, we don't have that much time to explain the details, but we have to say some principal words to the development. So first of all, we are speaking about the gonads. Gonads are, and we have to draw both female, male. So, and then starting with the gonads, definitely. So we can use one color, which will be used also later, and we know that this is testicle, and ovary. And then starting first of all with the rest of developing Wolffian canal. So I'm drawing the Wolffian canal with the remnants. These are remnants of disappearing mesonephros. So this, or we could say just remnants of mesonephros, correct, and then drawing the Wolffian duct plus the connection with the kidney, with the REN, like that. So repeating, here is the pelvis, etc., is the kidney, and then we draw the connection with the common cavity, which is called urogenital sinus, urogenital sinus, which gives rise to the urethra, and also the urinary bladder, right? Urinary bladder. Fine. So we see the same. The sinus has two portions because we need also the canals interconnecting the products from the testicle or ovary. So I'm drawing. Sorry, must be here internally. Yeah. Like that, drawing the connection, and the second canal. This is absolutely the same. You see, must be again you see the remnants, etc., drawing it like that. Yes, kidney, and so on. No need to draw anything else. So again, we see this urogenital sinus, the cavity, then the remnants, which are, first of all, here we see developing ureters, and then Wolffian canal. We already used green color for it on both sides, definitely. Okay, so these are the remnants of mesonephros, and using also light blue for the second canal, which is called Müllerian, ductus Mülleri, Müllerian duct, or ductus Mülleri, that one. So Wolffian and And here's again Wolffian canal duct. Fine. So this is what we remember about the basics of the development of the organ. This is not all, definitely, because now we fully understand the development of the urinary system. And concerning the genital system, first of all, at the central part, there is the indifferent stadium, and then from the stadium develop the organs as we will see. And then we maybe that much better than the discussion would be to compare the female and male organs, and starting with the indifferent stadium and explaining whatever will develop from each part. So I mean that we call it homologies or homologous organs, homologies of genitalia, maybe of genitalia. And in this table we try to explain the maximum. For any detailed description, please look at any book describing that embryology. But you see, we don't have that much time to start with detailed description of the organs, but we have to know some basic terms. This is just the matter of the basic terminology. Okay, so looking now at the organs, here would be indifferent stadium. Yes, this is the same as we said, just gonade, and then we have to add some details. So this would be male, correct, and that was be female organs. Very quickly, starting with the gonade. No, gonade gives rise to the ovary, and also on the other hand, testicle. This is one clear point. Mesonephric remnants, as we see, they give rise also to some remnants. I will mention them, but we will not describe them in detail because they are found just rarely, but they exist. But I have to mention because this must be the review must be completed. Mesonephros just gives rise to some remnants. There is a special remnants situated close to the ovary. We call it epophoron. If you will read it, so then just don't forget that this is a remnant of these small canals. Fine, but in the male, regularly develop from the mesonephrotic remnant the efferent ductules. I would say epididymis. This is the we know this is the testis, and on this superior surface lies the epididymis, and we would just say that epididymis just the efferent ductus. Efferent ductus. I know that we already described, and you received this handouts, the information concerning the internal structure of the testis, etc. Then Wolffian canal, Wolffian duct, Wolffian canal. No, mainly it forms the organs. First of all, deferent duct, ductus deferent duct. We know that it opens into the prostate, and also ejaculatory duct, and also the ductus of epididymis. Epididymis, just duct, sufficient. In female, practically nothing. There's a special small canal, completely reduced. I will just mention, but it's very rare canal of Gardner. If you look at that, then very small remnant, practically without any sense. Sometimes it forms the cysts, and then it could be a problem, but normally not. Then Müllerian canal, Müllerian duct. informs mainly, gives rise to the uterine tube, then uterus, and principally also vagina, main part of vagina. Fine. In male pelvis, practically nothing, just prostatic utricle, and we will see it as a small blind depression in the prostate. Finished. What else? Genital, there is a special elevation situated at the center. Here at the center is called here at this level lies genital tubercle and torus and tubercle, etc., without any details, just looking. Genital tubercle gives rise to the clitoris in female, and in male the cavernous body of penis, logically. And also there is another elevation. This is the torus. This is genital torus. I will put below that genital. Genitorus means elevation to genital torus, and it gives rise to the labia majora. On the other side corresponds with the scrotum. Scrotum contains, two testicles. Then follows the bulb of vestibule from the same area, bulb of vestibular opening. Vestibule is surrounded by the bulb. We will draw it, don't worry. On the opposite side, we see the spongy body of penis, completed. Then next one, we go to the end, about vestibule, greater vestibular gland, corresponds with the bulbo-urethral Cooperian bulbo-urethral gland, done. Bulbo-urethral, then prostate gland or glands, plural, corresponding with the para on sides of the urethra, para-urethral glands. No, and what else? Maybe just last point, the scrotum. You see, scrotum has the raphe, because it contains two testicles, so no need to draw anything. Just to know, just to remember that scrotum has the raphe of scrotum. No, and this corresponds with the rima. Rima is the cleft. Rima of pudendal rima of pudendum. Pudendum corresponds with the external genitalia. So I'm 100% sure that this is sufficient, more than sufficient. The homologous organs done. Okay, so I mean that this was done, this was completed, and back to the organs, to the walls. So we did everything, and then on the next page we are speaking about the. Look at that. This was our introduction. Then follows the perineal. This is not that one. Here is that English version. Development organs, very short review, and then follows the perineum, urogenital diaphragm. But before we will start with perineum, we have to say some words to the topography of the. I mean that we can call it topographical relations. Topography of infraperitoneum, because infraperitoneal space, because without that we can. This is This is the which in fact is the same as the walls of the pelvis plus topography. Must be mentioned now. Concerning the walls, we did it, we completed, we fully understand, and then we have to say some words to the other relations. First of all, they are the pelvic fasciae. This is very important topic because pelvic fasciae form the coverings of the organs and also lining the cavity. Pelvic fasciae is divided into A and B. The first one is parietal, logically parietal fascia that lines the cavity. The second is visceral, parietal and visceral, both of them. Parietal, so we will divide them simply. Parietal forms the following, just the names, the obturator fascia, clear, covering the obturator. Then follows the piriform fascia, yes, covering the piriform muscle. Then it forms also the umbilical fascia. Also, this is logical. It ascends from the apex of the vesica urinary bladder running to the umbilicus. Also clear. Then must be the superior diaphragmatic fascia. Yes, that's the fascia covering the levator ani, and also the medial umbilical. It forms also median, not median, the central one, medial umbilical ligament and fold. Finished. So this forms the parietal, but visceral is more complicated. Visceral forms together the laminae, so it forms visceral lamina together with the fasciae, covering the organs, pelvic organs, forms together with the forms visceral fascia forms the laminae, or we can call it also plates. We call them plates. I have a diagram to show you the plates. We are looking into the pelvis from above. We see the urinary bladder. We see the uterus, just the neck of uterus, and here's the rectum. And then look, here are the this condensed connective tissue of the visceral fasciae and fasciae around the organs to form three plates. One is vesical, one is genital, one is rectal, plus the ligaments that stabilize the position of the organs. So we know that these laminae or plates, and we need very simple drawing, they surround the organs. So I mean that we can draw now simple drawing. There is a superior view. We are looking from above, superior view, where we see the organs. First of course, here must be pubic symphysis. Here would be the sacrum in yellow, pubic symphysis blue. No, it's not bluish. Here is bluish. Yeah, pubic symphysis. Fine. And then sacrum. I would add symphysis. Yes, sacrum behind. Good. Organs. Bladder. Yes. Neck of uterus and the rectum. Could be like that. So bladder anteriorly, neck of uterus, correct, and finally rectum. We need more place around, so then this will be sufficient. So just walls quickly, rectum and bladder, and different color, lighter orange for the neck of uterus. So we are at the level of the horizontal section, superior view, and now we are drawing 3 laminae. First of all, note please that there is at the key position the artery. We call it internal iliac artery. This internal iliac artery sends the arteries, vesical, uterine, and finally rectal arteries. The arteries plus veins, plus nerves, plus lymphatics, all of them run from these walls and form the condensed laminae. We are using light blue for them. So we see the laminae, the plates. The plates are 3 in number. I would use also the numerals. So number 1 would be the vesical. Number 2 is the genital, much thicker in female than men. And the last one is the rectal. So they are plates, just plates, 1, 2, 3. And on the other side of the drawing are bent, or is the bent, antero-posteriorly run also the bends. You see just drawing light green line, and drawing also the tails. We see that the bends form the ligaments that stabilize the position of the organs, the uterus, bladder, and also the rectum. So look how the ligaments run. At the center lies the cardinal ligament, ligamentum cardinale, because it stabilizes the position of the neck of uterus. So again, please, neck, not horn, not cornu. This is the neck. And we call this ligament the cardinal ligament, ligamentum cardinale, or transverse ligamentum, ligamentum cardinale of uterus. The other ones, but we will see all of them. The other one is the pubovesical, that one, because it's between pubis and vesica, and because there is no place, I just put maybe not small letters A. A is the pubovesical, I would say ligaments, pubovesical. And also puboprostatic, puboprostatic. This is its inferior portion, prostatic. Done. This is A. Then follows the second one, which is vesicouterine. This would be B. Vesicouterine. Cardinal, we said, this is that one, it's like fun, attached to the walls of the lesser pelvis. Rectouterine, there is the rectouterine, there is place, but we could add C. C is the rectouterine. Yes, rectouterine. Then sacrouterine, sacro. This is D, sacrouterine, and also rectosacral. That one is rectosacral, is the E, rectosacral. Sometimes they'll use also the opposite, sacrorectal. Rectosacral is correct. So we see the ligaments, stabilizing ligaments, also stabilizing the position of the uterus, and returning back to the plates. The plates contain, so concerning the contents, the plates colored by very light blue, corresponding with the same one, and plates contain, again, the branches of iliac, of internal iliac artery, plus veins, of course, and plexuses, plus nerves, autonomic and sensory nerves, and also connective tissue, tissue and lymphatics. So all these structures are found in the plates. The plates are very important. Concerning the spaces, there are also spaces. We have to mention them, spaces. And using probably dots would be better. So the space situated in front of the bladder in one, then behind that with 2 dots, then pararectal 1x and retrorectal 2. So 1, 1, 2. Good. The first one is called simply prevesical space with 2 dots, retrovesical space with 1x is pararectal on sides, and with 2x this is retrorectal. All these spaces, retrorectal, they contain the soft connective tissue. I would just add arrow, soft connective tissue, and the soft connective tissue is important for the movement. So permits it. The tissue permits what? No, permits the movements, the dilation of organs, of hollow organs. That means urinary bladder, or also rectum, and growing pregnant uterus, definitely. So it contains soft connective tissue, all these spaces, but also, this is one important point, permitting the movements, but also note that the spaces, because they contain just soft connective tissue, they also permit relatively quick spread of infection. Also, unfortunately, spread of infection, because the bacterial infection passes quickly, infection through the spaces. No, and concerning the tissue, connective tissue, we said the connective tissue that contain these plates and around the plates and around the organs. So the connective tissue is called also into plates. So another terms, using another terms in the plates or around the plates or around, we will say terms of tissue around organs related to the plates. So we will use again 1, 2, 3, and we know the names. The first one is called simply paracystium, because it belongs, it belongs to the soft tissue around the, or on sides, but on sides, the around the organs. A paracystium, tissue around organs. Okay, paracystium. Then parametrium around the uterus. Parametrium, correct. And also paraproctium, because this procto is the prefix for the rectum. Paraproctium. Okay, so we know the terminology, we know the spaces, we know the ligaments, we know everything about the facial system or facial coverings in the cavity. So I mean that it's also done. Next page, please. In the next page, what we see? We see another one important relation, which should be mentioned, and this is the relation to the of the uterine artery, and also the ureter. So we need one page. We could say relation of the uterine artery and ureter. That's important to know. Quickly, when we draw the coronal section, again, we try to do the best in our illustrated review of anatomy. Drawing here the uterus, find the cavity, isthmus cervix, like that, okay? Just drawing the caudal portion of uterus, the wall, then drawing the attachment of vagina. So we could say vagina, and here we have the uterus, the wall, uterus, yes, and coloring also the uterus without, because the myometrium is the thickest part, just simply coloring, yes. So we see uterus, vagina, and drawing now the wall here. So at this level, we call it lateral fornix. It's not bad to know that this space is called lateral vaginal fornix. So around 2 centimeters from the wall of the attachment of vagina to the uterus passes the uterine artery, approaching to the wall, uterine artery, draw uterine artery. It divides into the uterine artery with typical zigzag course, supplying the uterus and also supplying the vagina by the vaginal branches, and then drawing the position of the ureter. So ureter lies at this position. Here we see ureter, which is approximately 2 centimeters from the wall, at around 1.5 centimeters above the fornix, right? So in this position lies the uterus, and also because we have this place, we would add also one lymph node. That lymph node is called the parauterine node, lymph node, nodus, parauterine nodus of Bayery. This is one of the important lymph nodes situated on the sides of the uterus. So I mean, this is also very important relationship. We completed. Fine. And then speaking about the infraperitoneal space, so this is the point we said, number three, okay, yes, perineum. No, first of all, speaking about the subperitoneal space, definitely. So subperitoneal or infraperitoneal space, infraperitoneal space contains the organs like the urinary bladder, ureters, caudal part of ureter, prostate, then urethra, rectum. So we have to say some words to all these spaces, to these organs. So they are organs. Of course, there are many organs, but we start with some of them and trying to just mention some topographical relations between these organs. So starting with number one, urinary bladder. urinary bladder. We will see also differences between the male and female. Concerning the urinary bladder, we know that, just short review of terminology because we need it. So if we see the bladder, a typical triangular bladder, I try to show you also the covering this is the superior covering by peritoneum. Here is the we know that from apex ascends the umbilical ligament. This is the medial umbilical ligament. Yes, here we see the apex, we know it. That one is the body corpus. Here, if we draw also the prostate, why not to draw the male and also the floor? We know that this is the urogenital diaphragm, sufficient. So that part is called fundus, fundus of bladder. Here's the fundus. But that portion where the urethra passes through the wall into the urogenital diaphragm in female or into the prostate is called cervix. So that portion is called cervix of the bladder. Now, a bladder is covered, we know, covered by peritoneum superiorly. This is what we said, peritoneum. Yes, and also on the sides by paracystium, which is on sides. This is the soft connective tissue. No, and is covered by some fasciae or has relations to fasciae, which are two, anteriorly and posteriorly in both sexes. Anteriorly is called the vesico umbilical fascia, vesico-umbilical, which ascends to the umbilicus. This is like triangular like that. And dorsally, posteriorly, it forms the septa. A row forms septa. That's important for the organs found in the peritoneal cavity. And septa are two in number. One is called vesico-vaginal septum, and the second one is called the rectovesical. We will draw a diagram, rectovesical. No, in surgery, the surgeons know under the name Denonvilliers. Denonvilliers in surgery, because they know it for the from operation of the rectum. So Denonvilliers fascia. And we know also there are two pouches, or we call them also excavationes, excavatio, and there are two. One is called vesico-uterine anteriorly, vesico-uterine, and recto-uterine. So vesico-uterine anteriorly, recto-uterine posteriorly, or recto-uterine Douglas. Also in male is called logically rectovesical, right? This is the, or in male, rectovesical in, so in female that one is in male, right? Rectovesical in recto-uterine in the second one. Okay, so we can add, because we need a simple drawing. This is the vesico-uterine, would be number one in the diagram, and recto-uterine would be number two. rectovesical is in male. So if we draw now the female pelvis, and we have to draw minimum one sagittal section. So that's why we have to mention both depressions. So what we draw is the would be sagittal paramedial or paramedian sagittal section now. Sagittal section, yes. So we are drawing now the sagittal section, and on this section, what do we see? The position of uterus anteversion, anteflexion. So here drawing the fundus like that, body, etc. Attachments of vagina would be sufficient. So drawing the position of uterus, correct. Posterior fornix of vagina, correct. Fine. Then the position of the bladder and urethra, which runs together with the anterior wall of the vagina, could be like that. Of course, some ligaments. This is the median umbilical ligament. Then drawing also pubic symphysis, attachments of the muscles and facial coverings of the anterior wall, drawing the urogenital diaphragm, passage of urethra of vagina, then central tendon would be green, that lamina called the rectovaginal septum, right, rectovesical, and right, rectovagina would be fine. Okay, then drawing also the sphincter external rectal or anal sphincter, and then finalizing it, drawing the rectum in with the ampulla and canal in the typical position, like here, and also the coccyx and sacrum. Okay, so this would be like that, and here we are drawing. Here would be the labia minora, labia majora. Okay, this would be like this, sufficient. Fine. So just the outlines. Rectum. Before we will do, or first of all, we have to draw here with the ligament. Yes, that's it. And first of all, we have to start with the peritoneal covering. So we said that there is the depression, or better, this is the pouch, and then peritoneum covers the major part of the surface of the uterus, including posterior fornix, and then here's the depression, and then peritoneum. So we see the peritoneum, and we remember that peritoneum forms two depressions. This is number 1, and that one is number 2. This is much deeper. Then we see the uterus here. Covering of the uterus, I mean that we can draw also the attachment of tuba uterina, then surface of the bladder with the wall. Here we have the wall of the bladder, right? Okay, then urethra, yes, vagina, and then also the urogenital diaphragm, the muscular, but also not only muscular, but also membranous part with the central tendon, very important organ in the, or center in the female pelvis. We are looking again at the section. Here we have the sphincter and the ligament. Yes, this is the ligament. So coloring also the external sphincter. And because we are drawing also interior, we said that we are at the level of the Kohlrausch. I'll just put Kohlrausch's valve. We know that it's around 6 to 7 centimeters from anus. This is what we remember. So that's why I'm drawing also the fixed valve, and then this on the right side, the X dexter, because we know that on the left side are irregularly situated valves. So I mean that this is absolutely correct with the wall of the rectum. Yes, and then Kohlrausch's valve. Fine, excellent, excellent. So we see all, plus here you could add the external anal sphincter, correct. And then here is the central tendon. Don't forget, central tendon or tendon, or perineal, we call it so perineal body. So central tendon or perineal body, important in obstetrics and gynecology. I mean, that is sufficient. We know that the central tendon stabilizes the position of the vulva. Vulva means the external genitalia. And during parturition, delivery of the child, labor, there's a risk that the central tendon and whole perineum could be ruptured. That's why they make episiotomy, they make they cut it in well-defined position, avoiding any rupture. So important for obstetrics and gynecology. What else? We have also the bony parts. This is the sacrum and coccyx. That ligament, we said it several times, this is the anococcygeal ligament, we said, coccygeal ligament. Here is that posterior vaginal fornix. Don't forget that this is also the posterior vaginal fornix represents the approach of the surgeon, because here in the to the peritoneal covering or the Douglas's pouch, because here could be, in some cases, in some infections, could be accumulated the fluid or pus or blood and so on, so they can perforate it by a strong needle and remove the fluid. So fornix vaginae, the posterior vaginal fornix. Then the bladder, definitely. Here is the median umbilical ligament done. Symphysis, yes. Then the space here is we call it retropubic or prevesical space, urogenital diaphragm, yes, urogenital diaphragm, done. And then sometimes we said orifice of vagina. Here is the orifice, external orifice of urethra, female urethra, yes, and here is the vaginal orifice, vaginal orifice, yes. And then finally there are two septa. That one is the posterior septum in female pelvis. You see, is attached to the floor of the peritoneal depression of the pouch. We call it septum recto vaginale. So recto vaginal. Do we have place? Yes, we have. This is the recto rectovaginal, vaginal septum. It doesn't exist in male because there is the rectovesical, and another narrower septum lies also here behind the anterior wall of vagina and posterior wall of the bladder, and we call it vesico. We have place, yes, for the name arrow. We call it vesicovaginal, vaginal septum, vesicovaginal septum, yes. So we see the septa, we see the situation, we see also the organs. Of course, using light green, we can color the spaces around the organs, which, as we said several times, contain the soft connective tissue, lymphatics, lymph nodes, nerves, etc. So just the septa must be a little bit thicker. Good. So then we could add that in the block we are drawing that light color, we'll color them, and we can say that around organs are the venous, because we know venous plexuses, venous plexuses, yes, plexuses, and we see them when we look at the diagram here. What we could demonstrate here are the different vessels, different arteries. Definitely, we understand that for instance, that one is the uterine artery, supplying the uterus. Here we see the typical zigzag course. This corresponds with the enlargement of the uterus during pregnancy. But there are more arteries, definitely. There are arteries that descend. This is the inferior vesical artery. This is the uterine. Here is the branch of the pudendal internal. Here is the branch of the superior vesical, etc. You see the direct approach of the arteries to the urinary bladder, to the uterus, to the vagina. But veins form plexuses, not the separate veins. They form the plexuses, not the tributaries, and they open into the larger veins. They open finally into the, as we said at the beginning, to the vein, internal iliac vein, which lies on the lateral side together with the internal iliac artery passing through the through 3 plates. This is what we already mentioned. And they form the venous plexuses, and the plexuses, we know the names. This is the plexus is simply called the rectal plexus, right? Rectal plexus, first point. Then uterovagina, next one, uterovagina, vesicoprostatic in male, prostatic, or vesical in female. So like these 3, they are the most important ones, and they are interconnected. This is one thing important, because this interconnection permits the spread of infection. But these also form the interconnections with the, I would put the interconnections with the external and internal vertebral venous plexuses, and these plexuses and the interconnection permits or form the direct channels for the spread of infection. So these interconnections, important, represent the direct channels for spread of infection and malignant cells. That means tumors even into the vertebral column, vertebral vertebral column, canal, vertebral canal, maybe canal, or vertebral column. You see, that means that even the infection or malignant cells, that means from tumors situated close to the pelvic organs, could be spread via the interconnections into the vertebral canal. So that's why we can find the tumors in long distance from the origin. Correct. And then finalizing the position of the vesica, we see also smooth muscles, smooth muscular bands on the basis of bladder. Yes. Just sketch urinary bladder like that. Then urethra, pubic symphysis, rectum. Okay, rectum, urinary bladder, symphysis. Good. So we see now we are looking at the floor and drawing 3 bands. One, or maybe this color would be sufficient. We are drawing the band which runs around the urethra and bladder. This runs around that. And the first one is called pubovesical muscle, pubovesical. Then the second one, another red, rectovesical, descending from the wall to vesica, to bladder, and then this is that band. That band, we call it rectovesical muscle. And finally, the last one, which can maybe orange, from the bladder, from the urethra, or from the anterior wall of rectum to urethra, we call it rectourethral, rectourethralis, urethralis muscle. So even these 3 smooth muscles are situated on the inferior side of the bladder. So this was the point number 1, the urinary bladder. But there is also the second one, number 2, which is the urethra. We call it male and female urethra, or we call it also the masculine and feminine urethra masculina, urethra feminina. So we have to say some words also to the topographic relations of the urethra and male and female pelvis. So when we look at this urethra, or this urethra situated within the pelvis, so next paper, and then maybe that, I would say again urethra, maybe that the best way would be to compare the male and female urethra. This is even better. So we are looking at the female urethra, male urethra. Sorry, this is like that. And then just some information concerning we know the length of the urethra is around 4 centimeters and transverse diameter 7 to 8 millimeters. A length of the male is more, around 20 centimeters approximately. Then discussing and looking at parts are completely different. So we call it, first one is called intramural, the terminus technicus intramural, which means within the wall. I would say within the wall of bladder, right? So descends from the wall of the bladder. Second one is called pelvic portion, simply passing through the pelvic space. And number 3 is the perineal. So that means it passes perineal through the perineal, that means urogenital diaphragm. There are 3 portions, 3 parts only, but in the male is number 1 is the intramural, is the same, intramural. Yes, there is a sphincter. Number 2 in male, not in female. Number 2 is the prostatic part of urethra. Number 3 is the membranous part, membranous, because it passes through the urogenital. I would add below that through the urogenital diaphragm, where is a sphincter diaphragm. Also in both sexes is the sphincter. Number 4 is a spongy part, because it passes spongy part through the penis. Right. So there are 4 portions. No, the female urethra descends or is connected with the anterior wall of vagina, and then it forms here. It forms in the vagina we call it crista urethralis, urethral forming here, urethral crest of vagina, urethral. When we see the vagina, so there is a crest. You see this the cross section of vagina. So this is the urethral crest here, vagina, the wall of vagina, like that is the crest. Yes, crest of vagina, that's it. Fine, of vagina. And then here there are 2 curvatures, A is the subpubic, which is fixed and corresponds with the position under the pubic symphysis. No, maybe that much better would be just the diagram. I will not draw. I really don't have that much time. You see, this is the subpubic curvature. Then there's a prepubic, which is mobile. So the second one is the prepubic, which is mobile, important for the examination. Fine. And then maybe one diagram would not be bad. What do you think? To draw the floor of the bladder, then here we see the urethra. I'm drawing a wider urethra than normally because I would like to draw more structures inside. Yes, this is like that. Fine. Then terminal part. Terminal is the enlarged navicular fossa. Very good. Then drawing also the prostate. Then the urogenital diaphragm. Then the spongy part with the bulb of spongy part, forming the glans penis, finally. And the same is on the opposite side, like that. Fine, good, done. No, this must be symmetry, so it could be a little bit narrower. That's it. Fine. Okay. And then we also remember there are the cavernous bodies. Done. Finished. So coloring cavernous bodies, we know this is a typical erectile tissue on both sides. Yes. Then this remain white. Coloring also the interior of the urethra, the passage of urethra. And then the wall of the bladder, where is also the sphincter, the internal sphincter. Here is the uvula, it's a small elevation, uvula, we call it uvula. Of vesica. then prostate, yes, prostate, the urogenital diaphragm, better writing, urogenital diaphragm, correct, with the muscle, maybe dark color would be like that. There is a sphincter, that's why I'm drawing dark one. In white color, there is the urogenital diaphragm. We know that there are also bulbourethral glands. No. Here is the spongy body, bulbous spongy body of penis. That one is cavernous body, cavernous body of penis. Fine. Here's the glans penis, and here is the navicular fossa. Navicular fossa. Good. What else? No. And here I'm drawing also that crest plus the elevation, drawing carefully, and the elevation are 2 dots, 3 points. So maybe that because what we need just one sentence to the female. So maybe that this would be sufficient. So I would draw the detail. Where is the, you see, there is the sinus. Is a prostate, right? Here is the elevation with the crest. Elevation contains 2 openings and 1 blind one, plus many small dots, the gland. So I will define it, I will describe it. So this is detail of the previously mentioned view into the male urethra. Well, okay. So this is the uvula. Here is the colliculus seminalis, seminal, the elevation, I would say elevation. Here is the seminal colliculus. Do we see it? Yes, we still see seminal colliculus. Then this is that one, right? This is the seminal colliculus. The space is called sinus. We call it prostatic sinus, right? There are the orifices, I would say openings of prostatic glands. This is quite clear. And then here are 2, look, here are 1, 2. These 2 are the openings of the ejaculatory ducts. Openings of ejaculatory ducts, right? And 1 unpaired openings is called prostatic utriculus. And we said at the beginning, when we briefly described the development of the Müllerian duct and also the Wolffian duct, that this is the remnant of the Müllerian duct. That's it. And here this crest is called simply the crista urethralis. Urethral crest. So there are so many structures crest. Fine. Back to the there is maybe not bad to draw also the cross section. So, or what we see at different levels, because here is the like asterisk, because it's a sphincter. That one is the different shape, because from below run these ejaculatory ducts. At this level is again like asterisk, because surrounded by the sphincter. And here at this level is like the more or less vertically oriented plate, and in the terminal portion vertical cleft. So when we look at the section and the cross section of the urethra at different levels, we could say yes, they are different position. Intramural is number 1 using black color, just numbers, because it corresponds with the numbers. Here we see number 1. We are maybe even better would be darker red. So repeating number 1, number 2, number 3, number 4. Yes, here is number 1. Number 1. Yes, that level. Here we are at the number 2. This is prostatic. Then that one is number 3. And here is number 4. Maybe that just here is number 4 at the different levels. Okay, so I mean that this is very clear. Here in the male urethra, there are 2 sphincters. One sphincter lies here, the second lies here. So there are two sphincters. One is smooth, definitely. One is striated. And if we add also some information to the female, we could say that it descends together with the vagina, and there is only, we could say, only one sphincter. Yes, that means that one is here. It's the sphincter at the level of the urogenital diaphragm, right? So then just the voluntary, only one sphincter, and the wall contains one sphincter, and wall of urethra contains longitudinally passing fibers like that. So there is a urethra, you see urethra, and if the longitudinally arranged fibers contract, sorry, it must be opposite must be, if they contract like that, so then they contract and dilate. So contraction, wall contains the longitudinally passing fibers. If they contract, so then dilate. Of course, the contraction leads to the dilation. This is dilator, in fact, dilator of urethra. No, I'm sure that this is more than sufficient. So we did the best. This is the urethra. And then we have to speak briefly about the rectum, also important topographical relations of the rectum, and then also the ureter, and also the position of the uterus. So I mean that controlling the time, and that is good and sufficient. So next page, please. We are looking at the position number 3. Structure number 3 is the rectum. We know the rectum is around 12 to 15 centimeters long, and transversally 4 to 8 centimeters. Rectum has the ampulla dilated, ampulla wider part, ampulla which is 10 to 12 centimeters long, and is we know that it's like that, right? So we see the convexity. This is concavity, because so follows, this is the ampulla here, we see it, and here's the sacrum. So in fact, the curve copies the concavity. So I would say lies in the concavity of sacrum. Done. Lies in concavity of sacrum. Then as we said several times, there is a chlorauchus valve. It's quite clear. And the second one is the anal canal. Anal canal is analis, which is much shorter, 2.5 to 3.5 centimeters, also narrow. But we will not say any extra terms or any extra words to the anal canal, because we will draw a diagram, and in this diagram we will also explain the situation with the anal canal. Yes. So speaking now about relations, they should be summarized. Relations of the rectum. of the rectum in the relation to the other organs, relations of the rectum. No, quickly, posteriorly, what lies posteriorly? Sacrum, coccyx plus as we said, coccygeal ligament. In drawing of the perineum, we will also draw the position of the ligament from above, viewed from above. Sympathetic trunks. Yeah, they descend. Trunks just partly, but they are there. Then what else? Then hypogastric plexus. Hypogastric plexus. This is mixed of the sympathetic parasympathetic fibers together. Artery plus vein. Sacral artery plus vein. Median and lateral. Yes, they must be on the posterior wall. Then posteriorly, find laterally, no, elevator ani, parts of the elevator ani muscle, very important muscle supporting the organs, with the puborectal portion, puborectal part. We said that puborectal muscle is part of the elevator ani, but responsible for the contraction. So this is in fact the tertial sphincter. Then coccygeus muscle situated dorsally posteriorly, and finally anteriorly. What we see anteriorly, this is the septa, definitely septa, and we just repeat rectovesical and rectovagina. Fine, rectovesical. And then around half page we need for the relation to peritoneum. I could say peritoneal relations. So two schemes showing the peritoneal relations, peritoneal relations. Yes. So we need two drawings. One would be the superior view on the left side, and here would be the section. Which one? Coronal is the best. Coronal section. Yes, coronal section. If we look at these two, they will help us to understand the relations, the position relations of the rectum and also the peritoneum. No, look, when we see the rectum from above, this is the rectum R, and we remember that rectum is covered by the visceral peritoneum, correct? And also dorsal, posteriorly, there is the attachment to the posterior wall. We remember from a short review of the development of the organs found in the abdominal cavity belonging to the gastrointestinal tract that there is called mesorectum. We could say what we see here is the mesorectum. We know that mesorectum is the same as mesogastrium, is much shorter, disappearing quickly, but it's just short valve. And then drawing the parietal peritoneum. Moment, we have to draw the median plane, and we have to draw also some levels. Yes, would be like that. And we need also the attachment of the anal canal and also the floor. Would be like that. Good. So drawing the same on the other side, drawing the depression of the peritoneum, because now we are at the level of the coraceous valve. I will just put coraceous folding. We are at this level, right? This is the level of the fold of corace. Good. So what we see, this is the peritoneum, peritoneum. Which one? That one is the visceral, visceral, correct. And that one is parietal, parietal. We see two peritoneal covering, visceral and parietal. And on sides, there are depressions just drawing this deeper, not pouches, depression, we call it pararectal recess. This is the pararectal recess, right? Pararectal recess. Good, fine. And here we are at the level of the coraceous fold, which is when we draw now using the dotted line, drawing now the ampulla and the anal canal. This is like that. Okay, there is a symmetry, doesn't matter. So here is the ampulla, correct, and this is the anal canal, right, this is the anal canal, fine. Here is the anus, opening is the anus, correct, and the cleft is called crena ani, not bad to know this terminology, fine, crena ani, important for examination. So we see the super anterior view, we see ampulla, the anal canal, again repeating the distance from the anus is 6 to 7 centimeters. That's it. No, and then drawing now the coronal section. What we need? We need the bony portion. Yes, would be like that, sufficient bony part. Then what we need? We need the moment. We have to add one more thing. We remember that around ano-rectal junction, that means junction between the ampulla and anal canal, there are fibers forming the band of the muscle, which runs anteriorly, surrounding as the loop the rectum dorsally posteriorly, and the muscle is simply called puborectalis. Rectalis. All of us know that puborectalis muscle is the muscle acting as a tertiary sphincter. It contracts, closes the anus, relaxing in defecation, opens. So this is the puborectalis. So drawing here the muscles, this must be the obturatorius internus with its typical duplicature forming the pudendal canal. Then we see the attachment of the puborectal to the wall, to the lateral wall of rectum. So drawing now the wall of the rectum, like here. Here would be internal wall and then callaceous valve, and then here I'm drawing, okay, this would be like that, no, a little bit lower, but doesn't matter. Fine. Colors. First of all, drawing here the levator ani and the attachment representing this dark brown color. This is the puborectalis. Again, puborectalis. Fine. Then coloring the bone with because this is section, some dots, yellowish, sufficient bone. Fine. Then drawing the internal obturator. This is this internal obturator muscle covered by the fascia and also arcus tendinous levatoris ani. Here is the duplicature, maybe lower position, doesn't matter. This is the pudendal canal. So you can add that here. We see what we can do. Here is the pudendal canal, pudendal canal. That's it, pudendal canal. And the space here colored by light green is the ischiorectal fossa. Ischiorectal fossa. Here you can add and place the dot. Ischiorectal fossa. Ischiorectal fossa. Fine. So puborectal done. Levator ani. We could say levator ani muscle. Ani muscle. This is that one. Of course, covered on both sides by the fascia. We call it fascia diaphragmatica. Diaphragmatic fascia on muscle plus fascia. Fine. Now, here is then here is the wall of the rectum plus the bluish line that shows the depression. You see we are at the same level because now we are in the Douglas's pouch. So we are in the depression called the pouch, the rectovesical, this is blue, rectovesical pouch. No? Okay. And then concerning the wall, first of all, there is also tissue and so on, so on. I'm just drawing the vertically passing fibers, plus their enlarged portion forming the internal sphincter. This is the longitudinal type of the fibers. Then we see also the circular fibers. Here is also the sphincter, circular fibers like that. And then placing dot here, I mean, it's not bad to place here the Colruysch's fold, and here I'm doing the same. This is Colruysch, you see, at the same level. Very good. Of course, here is, again, definitely the soft tissue. No, so here we have that canal, the pudendal canal with the pudendal artery, nerve, vein, etc. So here what we see are the longitudinal fibers, longitudinal. That one is circular fibers. There you see circular fibers done, and then there's a mucosa, etc. Don't forget to place here the plexus. We call it the hemorrhoidal venous plexus. We remember this plexus as important in some cases. Of course, it also closes the anus, but in case of the cirrhotic liver, when the passage or flow of blood is reduced through the tissue of the liver, so then the corresponding parallelly running channels substitute the flow of the blood, and then the peripheral plexus is also become larger. They can be ruptured and bleeding follows. So the plexus is also important. So here this light red indicates the internal anal sphincter, right? And then follow three portions of the external sphincter, the darker red, in darker red, 1, 2, 3. So there are three portions. We could say this is the external sphincter, anal sphincter with three parts. There are parts, yes, and this is the deep, the most cranial, then superficial, that one, and the third one is subcutaneous sufficient. So these three portions. So I mean that also is not bad to see this diagram. No, and counting minutes. And then in the next page, what we see in the next page, it must be the general view looking at the relations of the ureter. I mean, this will be number 4 because number 3 is the rectum. As you see, rectum number 3, following number 4. I just put ureter, and ureter crosses in its course some structures. They are iliac vessels, external iliac vessels. It crosses also the obturator vessel and nerve. Inferior vesical artery forms the ureteric plica and also crosses the ductus deferens, deferent duct. Maybe that one view, I would say this is the medial view when we look at the structures found in the pelvis. So then one simplified drawing would be much better than long description. So I'm drawing now the internal iliac vessels, external iliac vessels, and then drawing the bladder, drawing the urinary bladder. We can draw bladder with the prostate, so that's why drawing the male pelvis in order to draw also the deferent duct, so then it will be more effective drawing that duct. A duct runs around. We usually draw it as a tube passing around the bladder, crossing the vessels, but as you know, passing through the inguinal canal. Fine. Yeah, the wall of the bladder. So first of all, we have to color the wall of the bladder. So this is the medial. In fact, we are looking at the mediolateral view. So this is like that. The urethra, wider, etc. Light blue for the seminal vesicle, ejaculatory duct, then deferent duct, ductus deferens, deferent duct. We see how it crosses the structures. Then we see also the urogenital diaphragm with the sphincter. This is what we said several times. And then the urethra passing through the bulb of penis, etc. So I mean that this is absolutely sufficient. Then coloring the vessels. Moment, we have to draw first of all also the descending. There is descending ureter. Descending ureter like that, crossing the vessels, passing behind, descending on the dorsal side, crossing here the deferent duct and perforating the wall of the bladder. Preferably coloring the urethra and ureter by yellow because of the urine. Here we have it. Okay, this is the ureter, and finalizing the drawing, coloring now the vein. This is the external iliac vein and the internal iliac vein, and here using red is the common iliac, external iliac, internal iliac. That's it, fine. So this is absolutely clear. And now what we need is the obturator artery, which enters the obturator foramen. I just put one opening, obturator foramen, and it descends to the obturator nerve. So I'm drawing black line showing the obturator nerve, correct, plus, this is sufficient. Then here I would label the internal internal iliac vessels, internal iliac vessels, artery and vein. So then ureter, repeating ureter, common iliac. This is quite logical. Here we see the inguinal canal through which passes the deferent duct, ductus deferent duct and its relations. Wall of the bladder, not necessary. Prostate, not necessary to add. Seminal vesicle, vesicular gland, also glandula vesiculosa. We could say also using another word, seminal vesicle. Both words are used, seminal vesicle. Good. And then what else? We need also the artery, which descends here. This is the internal. No, this is not internal. This is the inferior vesical artery. Inferior vesical artery. So obturator nerve. This is that one. And here what we see, obturator nerve and artery, yes, because they run together, but the artery is a branch of the internal iliac vessels. So what else? Ureter descends dorsally, dorsocaudally, crossing the external iliac vessels, and then crossing the obturator nerve and artery, crossing the inferior vesical artery, and crossing also the deferent duct. So here the ureter, in fact, forms the plica, the valve. We call it plica ureterica, which is seen from above in the peritoneal cavity. So I mean that this diagram shows very well the relations of the ureter and also the deferent duct to the other organs. Some words to the uterus, because we know that uterus lies at the center, very important organ in the female pelvis. In some notes, we already mentioned that the uterus, in fact, is stabilized by some ligaments. Don't forget the position. Maybe that we already mentioned the position or not yet. I'm not sure, because you see I have not yet, because this is my second lecture, 6 hours without any break. No, concerning the position, not bad to draw. If we did it, forget it, but this is not bad to see the vagina, axis of vagina, I would say axis. Then this is the uterus, the neck, and here's the fundus, right? I would say fundus. So this angle is approximately 125, is called anteflexion, and here around 90 degrees is degrees is 90, from 70 to 100, definitely. It's called anteversion, yes. So this is what we are drawing, but also what we have to draw, so on the other side, the same, this will be like that, right? So this is quite logical. So I'm just repeating the same very simple sketch we are sketching. So anteversion, anteflexion, so it must be a little bit wider here. Okay, that's correct now, absolutely correct. And here we see the posterior fornix of vagina, that's it, nothing else. And if we remember that it was the peritoneum and the pouch, the Douglas's pouch, and so on, and passing around the bladder, etc., again, we said no need to draw anything else. But because on the lateral side there is the cleft in the covering, which is called ligamentum latum, broad ligament of uterus. This is covered by peritoneum. So we would say there is a broad ligament of uterus. So broad ligament has the posterior layer. So here would be drawn the posterior layer of that broad ligament of layer of uterus, and here's the anterior layer of that broad ligament, bluish, yes, because this is in fact the peritoneal covering of the uterus. And we see that there is a lateral side in which we can draw the uterine tube, attachment of uterine tube. This is one thing. Here is the ligament. This is the ligamentum teres of uterus, and that one is the proper ovarian ligament. Ligament ovarii proprium, or proper proprium, correct. And note please that here approaches the uterine artery, which runs in the typical course, you see. So again repeating, uterine artery. So this diagram effectively shows the position of the duplicature, or the covering of the uterus, plus the other structures on the lateral view. And then we can draw also one more diagram, which is not bad. Two diagrams. We are at the level of neck, so look at the neck of uterus. Neck, yes, section. And wall, this is wall of lesser pelvis. Maybe that these small drawings will be very effective to remember the position of this, what we said, very important cardinal ligament. So note please that cardinal ligament of uterus attaches or stabilizes the position of the neck of uterus to the wall of the lesser pelvis. While on the next drawing, when we look at here is the fundus, we are looking at the fundus of uterus, plus below that is the cornu, horn. We are looking at the anterior and posterior wall of the uterus. And then we are looking at the ventrally passing ligamentum teres uteri. This is the round ligament. I use promiscuous both terms. This is the teres, ligamentum teres uteri, which runs anteriorly and again passing through the inguinal canal. We remember inguinal canal, right? Is inguinal canal, drawing the ligament, right? Dorsally passes another ligament towards the ovary. So we are drawing the position of ovary. So overlays dorsally posteriorly with another ligament running cranially superiorly. And because the gonate we already used light orange color. And then here cutting just the part. Here we see the uterine tube with typical fimbri, and there is the isthmus and this ampulla and so on. So just you can add tuba uterina, uterine tube, tuba uterina. And we see that on the wall, on the side, ascends the artery, supplying not only the ligament, supplying also the wall, supplying also the tube, and also sending branches to the ovary. Ovary receives also ovarian artery. We know that ovarian artery descends from the aorta, right? So, and the ligament is called ligamentum here. Is also ligamentum. Yeah, this ligamentum is called ligamentum ovarii proprium, ligamentum ovarii proprium, we already said, this is on this diagram, and then that ligament is called, two arrows, sorry, using also green, and the ligament is called suspensory ligament, ligamentum suspensorium, suspensorium ovarii, not bad to know, ligamentum suspensorium ovarii. So note please that there are three structures situated on the lateral side, at the level of the horns, and this is the anteriorly passing round ligament, laterally tubularina, and posterior suspensory ligament of ovarium. No, and then I would say that the ovary lies in ovarian fossa, and in the multipar, in multipara, that means the woman having children, multipara, we call it Claudian fossa, which is, I would say, dorsal or simply behind the internal iliac artery plus vein. No, not bad to know that ovary lies in the ovarian fossa, Claudian fossa, ovarian fossa. Okay, we said no. This is maximum what we said, and then finalizing we know the depressions, the pouches. This is what we already mentioned. Claudian, we said Claudian fossa, urethra feminina was also described. So this could be all two organs found in the cavity. And in the last page, because time is passing, that is over, we are starting with the perineal, perineal pouch, or regio, not pouch, better is to say perineal region, regio perinealis, perineal region. So I don't know, I don't remember the number. So this is the simply, yes, perineal region, perineal region, regio perinealis, together with the floor, urogenital diaphragm. And we are looking at the position. Here we see the just tubera ischiadica, then tip of coccyx. This is coccyx. Here is the anus and rectum. At the center lies the central tendon. So anterior lies the pubic symphysis, then tubera ischiadica, and of course the bones, then tip of coccyx, yellowish, no, and then the muscles. Of course, there are muscles at the center, but at the moment we just draw one line dividing this area, which is bounded anteriorly by the pubic symphysis, posterior tip of coccyx, this is what we said, anococcygeal ligament, correct. Then the anus, yes, anus, with the sphincter, anus and external sphincter. Then here is the urethra, and in female orifice of vagina. This is the urethral orifice, urethral orifice, and that one is the vaginal orifice, correct. And ischial tuberosity. Why not to draw the internal pudendal artery? Yes, why not? internal pudendal artery plus nerve, pudendal nerve, okay, internal pudendal artery plus pudendal nerve, not bad to see. No, and then we see two trigones, two regions or trigons anteriorly. Which color could be used? Not yellow, no. Maybe without any color. Dorsally, posteriorly, we see the trigon. This is trigon. So anteriorly, there is the urogenital trigon, urogenital trigon, triangle, that one, and this one is the anal trigon, anal triangle. So there are two triangles. Boundaries are quite clear. Anteriorly, pubic symphysis, laterally, plus bones and ischial tuberosities, and dorsally posteriorly, because there is the levator ani and there is the gluteus maximus, dorsally posteriorly anococcygeal ligament or lamina plus coccyx. So the anteriorly, we could say this is the anal triangle. Okay, number 1, and urogenital number 2, maybe. We can use numbers or letters, doesn't matter. So starting with the anal triangle, what could be described in the anal triangle? No, not so many structures, just some points. First of all is the anus plus the sphincter plus external anal sphincter, right? Then this is one thing. Then there is the inferior rectal artery plus vein. Then pudendal nerve. This is what we mentioned, and internal pudendal artery plus vein, the vessels, and dorsally posteriorly also descend some sensory cutaneous fibers, nerviclunium, cluneal nerves, nerviclunium inferiores, just few fibers, just sensory. But it's not bad to know that also sensory fibers descend. Fine. And then also the skin is pigmented, pigmented, and contains hair and hair plus the apocrine circumanal circumanal glands. Fine, this is quite clear. And on site, there is a special area. In the last minutes, we are able to complete it. Is the ischiorectal fossa. We already mentioned that fossa in 2 drawings, but one should be completed with vessels. Nothing specific. Just look at the wall. This is Corrosion's valve. We are drawing the wall of the rectum. Yes, just the wall without any details. Here is the ampulla we know, and this is the anal canal. Fine. And you remember here is that submucosis venous plexus. That's it. And there are 3 sphincters also done. But what I would like to draw is the attachment again of puborectalis, levator ani, then obturator internus, the bone without colors. Then there is the cavity. Here's duplicature. So I mean that this is absolutely sufficient, like that. And then using these 2 colors, puborectalis, levator ani, in general, internal obturator, yes, bone, finished. So I mean that this is well-known diagram. then all these surfaces are covered by face sheet, but this is duplicature. And we said that here is the nerve, there is also the artery, and notice that artery passes to the wall, supplying by infrarectal artery. This also forms the branches that join the other artery, the second artery, which is called the internal iliac artery, joining here, passing, supplying the wall, and forming the next one, the artery that descends. So there are three arteries as you see them, plus using light green, covering the whole space, which is in fact the ischorectal fossa, and then dark sphincter. So this is what we know from previous drawings, but the names of the arteries are important. Here's the internal iliac artery, and then the artery is called a middle rectal artery from internal iliac. That one is the inferior rectal artery. Inferior rectal artery comes from the pudendal canal. That means, in fact, pudendal nerve plus the internal pudendal artery plus vein, correct? And then finally, that one with interconnections is the superior rectal. Everyone remembers that superior rectal artery comes from inferior mesenteric artery. So we see three sources. By the way, the inferior mesenteric is practically the main artery because it supplies a larger area up to the level of the anal canal. Together with the arteries run the vessels. So I mean, yeah, in the last 2 minutes we could say that concerning the veins. So these are the arteries. So I can put red dots 1, 2, 3. This is the inferior pudendal canal with the pudendal artery, and superior rectal artery from the inferior mesenteric. Concerning the veins, last notes for today, they are number one, there is the venous plexus around the rectum. This is what we said, venous plexus. And the venous plexus is drained into three ways: cranially into the inferior mesenteric vein, then centrally to the middle rectal vein and internal iliac vein, and finally caudally, which are interconnected. So completing the words, superiorly it goes to the inferior mesenteric vein, which goes directly into the portal vein, right? Portal, because it's a portal system, because the unpaired organs of the abdominal, including abdominal pelvic cavity, are drained into the portal vein. Then medially is the middle rectal vein, which is drained into the internal iliac vein, and finally the inferior rectal vein drains into the, first of all, into the internal pudendal with direct branches to the internal iliac. So internal iliac is the main vein that collects the blood. And as we said, looking now at we need different blue. Portal vein is one system. Iliac vein is the inferior vena cava, right? Inferior vena cava, better in black letters, in inferior vena cava. No, and using again the same but different blue portal vein, inferior vena cava. So these interconnections using very thick blue, these interconnections represent, I'm repeating that thick blue double arrow, the portosystemic. This is the portocaval or portosystemic anastomosis. We remember that portosystemic anastomosis, portocaval are important. They are practically three main areas. One is in the gaster, in the stomach, in the cardia of the stomach, because part of the stomach is drained cranially superior into the veins draining the esophagus. That means the azygos system. Then you remember the paraumbilical veins and superficial veins of the wall of the anterior or situated within the anterior abdominal wall, the second area, and the last area are the veins between the portal vein, between the inferior mesenteric and then the inferior vena cava of the lower portion of the rectum. So then, in case of the cirrhotic liver, again repeating, the veins forming the plexuses become larger, but larger means thicker, but not with a thicker wall. So the ruptures are quite frequent, and the bleeding from the plexuses, especially from the submucosal plexus as here, are frequent. So followed by bleeding in the patient suffering by this blockage of the cirrhotic liver. So don't forget the veins, venous plexus. So I think that the time is over. It's 1 o'clock. So we completed everything with exception. Unfortunately, the second one is not the, this is the urogenital trigone, and there is absolutely no time to complete it. Absolutely no in my hands, because you see, in 3 hours to complete all review of the organ situated in the infraperitoneal space, including some notes to the development, etc., is really very hard. So I know the solution. I will send you within 2 days the short review of the urogenital trigone, including the structures found there, and because there are 2 pouches, superficial perineal and deep perineal pouch, including some notes to the floor of the perineum, that means the urogenital diaphragm. Thank you for attention. We did the best. I hope that you joined the program. You enjoyed also some notes. I know it was very, very fast, so many notes, many diagrams, but diagrams were simple, and I'm sure that it could help you in your further studies. Thank you for attention, and see you in summer term.